Oh, you came back. Well, I'm glad because you're just in time for my presentation on IV line labeling in the ICU, an evidence-based practice review. I'm Baban Nedelkov. This is for Centenary University, Nursing 3301, Professor Jessica Shepard, August 20th, 2025. The first slide, we'll be talking about why this is important, why I brought you all here today to listen to me. IV line labeling and misidentification is one of the biggest risks that we as intensive care nurses face. It's not just something that can occur in the ICUs. It is more prevalent in a polydrip environment, which is part of our PICO question today. But it's something that can affect any patient in the hospital who has more than one drip. You get one line, no problem. You know what's running through it. You have two lines, takes you a couple seconds to identify it. 7 or 8 lines with high risk medications, I wouldn't chance it. The patient population we're going to be discussing as well are patients who already have hemodynamic instability. They're already unable to maintain a homeostatic state by themselves. They're compromised in many ways, not just the reason why they might be in the neuro ICU or the surgical ICU. We're using high-risk pharmacological interventions in a very high volume scenario. Not only are these medications high risk, but the medication errors equate to higher morbidity and higher mortality for the patients. It's not just giving somebody an extra Advil or Tylenol. What's the significance of this problem? Why did we choose to make this a PICO question? At baseline, Noon's study shows that 7.7% error rates occur between multi-drip, polydrip patient lines, identifying them, and medicating the patient. These errors in the ICU, as we said before, are life-threatening errors. They're not something that can be taken lightly, and they're not something that occurs once in a while. They can occur every single day, every single shift, every single time medication is administered intravenously, and there's more than one line. So, our PICO question: can IV line labels amongst critical care patients with multiple concurrent infusions decrease medication error rates? For this PICO question, the process of literature search that I conducted brought me to databases such as PubMed, CINAHL, Scopus, ProQuest from our own college. And the keywords that I was using included IV line labeling, ICU, medication, also evidence-based, polydrip, multi-drip. There were several ones that I had to taper off there at the end because unfortunately they kind of, diluted the results a little bit too much. After that, I received a total of 724 articles. These were narrowed down to 3 key research studies. These studies were further narrowed down from their 724 to the 3 with their relevance to my PICO question specifically and what process they used to actually conduct their research. I required these to be in the ICU setting, to specifically be with polydrip patients, and they contributed all their information through evidence-based scientific research studies, or the gathering of information conducted from such studies and implemented into actual practice. My evidence summary, just to glance over it quickly, we have Noons et al. There, 2024 study, relevant. Just to circle back there to our significance or our process of literature search, all of these studies are also done within the past 8 years. So Noons 2024 was a randomized simulation study It included 44 ICU nurses, color-coded labels, and label dividers, which maintained an idealistic view of the actual presentation of the IV lines at the bedside of the patient, dividing them visually to give you quick identification. And the results of this study not only proved that there was, in simulation at least, a 0% medication error with labeling and line dividers, but the time to identify the lines was quicker, and the medication errors were abolished. This is extremely important in the ICU setting because when you are not just identifying the lines, but identifying the lines in a situation where a patient is either about to crash on you and is becoming unstable, either hemodynamically or in another sense, whether they're going into some shock state, whatever the case may be, if you're trying to prevent a code scenario or you are entering into a code scenario, in the middle of a code scenario, whatever the situation that is emergent is, it is a situation that intrinsically holds an intense amount of inherent stress, and in those environments, it's been proven that individuals tend to falter, thinking goes out the window, even fine motor skills can go out the window. Something as simple as attaching a plunger to a IV line, you might miss. To eliminate those errors, to eliminate the human factor as much as possible in that high risk, high intensity scenario, IV line labeling and IV line organizers show amazing improvements, completely abolishing the medication error. This study was rated a quality of A, as per the rubric we utilized, and a strength of 3. Our next study by Krisnick was a qualitative study, interviews of 48 ICU nurses in UK hospitals. The process of implementation is where this will either fail or succeed to produce the same results that it produced in simulation in the other study by Nunes. This includes workflow management, this includes getting upper management involved, and this includes staff who have been there for years changing the way that they work. Initially, they might not know it's for the better, they might not think that it's going to make a difference, they might not even admit to making errors of the such. But if you can localize the training and implement it properly, this study proved that those would be your major barriers. Otherwise, the actual labeling of lines and line organizers inherently improve and completely diminish the risk of medication errors, which is what we're attempting to do here. The quality of this one was B, and the strength was 4. And by our third study there, Neurally, S, and Overdeck, FG, 2023, this really focused on the printing of, the supplying of and printing of predated, pre-colored lines and an adoption of a specific formula to implement these throughout all hospitals with the same exact color coding scheme, time scheme, so that wherever you work, you're following the same practice protocols. It doesn't require re-education, and it ensures that whenever you do transfer staff, or you have traveling nurses, or whatever the case may be, you maintain that same abolished rate of medication identification error. All 3 studies support labeling effectiveness. The simulation showed a decrease in error and an increase in efficiency, and an implementation need of training, leadership backing, and staff adoption. That's all here, right? Reiterated once more. IV line supported, or labeling is supported. Simulation, again, decreased all errors, increased efficacy, and what we need for implementation. The recommendations as supported by the research. We have to adopt the standardized color-coded timestamp labels We must ensure that the labels include time to help verify the potency and avoid infusion errors, because it's not just giving the wrong medication at the wrong time or in the wrong line. It's also the potency of the medication, the expiration date of the medication. Something like propofol, for example, an IV line should not be utilized for post 24-hour period. But every other line, for the most part, in ICU setting, is good for 4 days. So it's very easy to forget if it's not labeled. It's very easy to forget, even if it is labeled, that propofol is only good for 24 hours. But at least you'll know, and the nurse should take the proper action if the date label is there. The integration of this into the workflow is going to be probably the biggest barrier, because human beings are creatures of habit. They don't like change, and we're probably going to meet our downfall or our success in the implementation through the staff training requirements, the attitude of staff, how it's presented, and the attitude of leadership, and really how much they back this, how much they organize this properly. Including the line organizers as adjuncts was also proven to support the line labeling identification, and performing regular audits and competency checks. This wouldn't be scientific otherwise. To implement this into the hospital and simply just fire and forget proves nothing. There would be no success here. At most, you might see some improvement, some marked improvement. But to get the results that we saw in simulation, to remove all error, which is our goal here. Our goal is to do no harm, to make no errors and do nothing wrong to the patient, to have the best possible patient outcome. We have to implement it the same way it was implemented in the simulation, and that requires constant checking, constant audits, and a database of results so that we can course correct at that point if we see that something is not working the way it should. How do we do this? Well, the implementation plan is simple. We have the task force that's going to implement it at the hospital. We have the leadership buy-in. We need to convince all of them using these studies that this is effective, that this is going to be beneficial to the business of healthcare. We need to develop protocols. We need to secure and procure supplies. Make sure that we have supply lines and logistics that will not crumble, that will not get backed up, and will not develop a shortage, because when you are trying to implement something like this, if there is a shortage and a moment where the training or the behavior of utilizing these lines falls back into the previous behavior of the nurses and staffs, the easier behavior, then all confidence in this is going to be lost by staff, and they will naturally fall back to what's easier for them. Simulation-based staff training, piloting this in one ICU unit, taking results of that, auditing them, seeing the statistics, seeing how successful we were, did it match up with the simulation statistics, because that's the goal, that's what we're shooting for. And otherwise, if it did, if everything was successful, if we thought that the pilot unit run was well done, we move forward to the rollout across all units and continue to monitor them. So what's the conclusion here? Well, standardizing labels, errors went down to 0. We abolished errors in medication admin. This is one thing that we can do to ensure safety for patients in an environment that, although we're trying our best to bring patients back to the most healthy state, to essentially recover and heal patients, can also do the opposite, unintentionally. As per Pinky, the errors went down. Pinky, I apologize. Faster task completion rates. That, according to Nunes, the baseline errors were prevented, all of them. 0% error. And the success, once again, all depended on training and leadership. Can't stress it enough. If it's not backed by leadership, if it's not backed by the employees, if it's not adopted wholeheartedly, it will not succeed, just like anything else implemented in the hospital. So our answer to the PICO question, labeling is an effective solution and a perfect intervention to prevent medication errors that are specifically due to the polydrip environment, the line identification, the misidentification of those lines, and the administration of wrong meds. And here we have our references. Thank you for joining me today. I appreciate your time. Take care.